Well, good afternoon. I am Dr. Becky Lynn. I am at Evora Women's Health in St. Louis. We are a concierge holistic women's health practice, and we focus a lot on menopause and sexual health. So today I am here with Dr. Jim Simon, who is the expert, much longer than I've been doing this, in menopause and sexual health. As a guest here on the podcast. So I'm really looking forward to talking to you, Dr. Simon, and hearing what you have to say about some really fascinating and truly important topics. So I thought we'd start by getting a little bit of your background, your training, where you're located, and then I really want to hit on how you ended up where you are today.
So I'm the only physician ever to be the president of both the International Society for the Study of Women's Sexual Health, and Dr. Lynn's been a long time, highly active member of that organization, I'm happy to say, and also a past president of the North American Menopause Society, having worked in menopause for many years. My office is located 5 blocks from the White House. That's the White House, currently where Mr. Biden and family live. And I've been in that location for pushing 20 years.
Welcome to Intimacy Unmuted, the podcast that discusses intimacy, women's health, midlife, and menopause unapologetically. Whether it is low libido, painful sex, or it's just not what you want sex to be, we will talk about it here. Today's podcast focuses on sex during menopause, how to spice up your sex life, and the menopause experts' opinions on hormone pellets. And tell us where you did your training and your sort of career trajectory.
So actually, I did my undergraduate studies right in the shadow of your practice, Dr. Lynn, in St. Louis at Washington University in St. Louis, where I got a very good liberal arts education with a undergraduate major in Romance languages and a double minor in art history and music.
Wow. And then you decided to go to medical school after that, or did you take all the prerequisites in college too?
No, then I decided late in my undergraduate career to go to medical school and got a special dispensation from the dean to take a bunch of extra hours at the second half of my junior and senior year. And then I went to Rush Medical College in Chicago, where I'm originally from, and subsequently did my internship and residency right here in Washington, where I'm clinical professor at George Washington University, and then a fellowship in reproductive endocrinology and infertility at the Harbor UCLA School of Medicine in Torrance, California.
So how did you make that leap from reproductive endocrinology and infertility to menopause and sexual health?
Yeah, so that's actually pretty simple. I saw the real stress and impact of infertility and its treatment on intimate aspects of my contracepting and now concepting couples. Mm-hmm. The kind of, honey, tonight's the night we have to have sex, and then, 10:30 in the evening, I get a call, I'm having trouble with my erection, and tonight's the night, and we administered our fertility medication and our trigger shot, and we have to have sex tonight, and the night is getting long, and blah, 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 blah. Right. And I saw that in its bigger context about communication between couples, not only heterosexual couples, between couples of all types, and how they engage in intimate contact, intimate discussions, lack of those real deep discussions about sex and pleasure, and decided that there was a big gap in our knowledge and a big gap in trying to get that information out to women and couples. And so that's how I ended up where I am.
Oh, I didn't know that about you. That's so interesting. I definitely see that in my practice. Couples who've gone through infertility treatments end up coming to me with things like low libido and low sex drive because, sex became a group effort when they were doing fertility treatments. Oh, it's time, you got to do it and do what you're supposed to do, and then call your doctor and tell the whole team that you did it. And then it just becomes, it's not quite the same. And I hear you on the communication piece too. When things are working great, sometimes you can have a fine sex life without great communication, but when you run into some issues, then that communication piece is key. And I definitely think we don't talk about sex enough, right? Like,
Absolutely not.
Yeah.
And everybody assumes that they're going to be an expert just because they have the parts.
Right.
Not true.
Right. And I have heard it said actually by Kelly Casperson, and I've stolen this from her. Dr. Casperson is a urologist on the West Coast. Sex is the only thing where we're expected to be an expert, but nobody teaches us anything about it. And I just completely agree with that. It's a shame, but hopefully people like us are working to change that. And ISSWSH, the International Society for the Study of Women's Sexual Health, is working to change that, thank goodness. And I don't know, maybe it's because I'm in it, but I've definitely seen over the last 10 years, more people interested in women's sexual health and more talk about it and everything. So I didn't know that you started in the sexual health realm. So you started there first and then went to menopause?
So,
or do they overlap some?
Remember that most reproductive endocrinologists see women who are on the latter end of the reproductive scale. Now, that's not everyone. We see young women who are having trouble getting pregnant or whose husbands, boyfriends, whatever, have low sperm counts, and they can be quite young and nothing's working for them. But the tendency in reproductive medicine is to see professional women, professional couples, where she's over 35, has not been trying to conceive, and now is actively engaged in building her family, and it's just not working. And some of that is aging, and some of it is a variety of other problems, but that's how I started. And because they were aging women, I was looking at how their hormones were changing, how it affected their mood, their behavior, their sleep, their sex life, their fertility, obviously. And it was an easy transition from there.
Yeah. And what do you think is the like, if you had to give women a message about sexual health, anything that you would really want women to know that you think is important that we don't really talk about? Well, maybe you and I talk about it, but most women don't.
Yeah, I think the most important thing for women is that they deserve pleasure. And they are not engaged in sex for only the pleasure of their partner. And if they're having pain, or they're not having pleasure, or they're having difficulty achieving orgasm, or any number of other issues, then they should get some professional assistance, because they ultimately deserve to have pleasure in their sexual contact. And it shouldn't be a chore. It shouldn't be painful. It should just be a wonderful God-given pleasure.
Absolutely. I agree with you 100%. And I hear that every day in my practice. Many women say, well, I just have sex because I know I'm supposed to, and I don't really enjoy it, and I just get it over with. And I agree with you that I feel like many women think that's just what they have to do, or that there's no treatment, there's nothing they can do for painful sex, or there's nothing that they can do for low libido. And actually, there are plenty of things that women can do, maybe not as many, things that as for men's sexual issues yet, but you don't have to suffer in silence.
Yeah, we have lots of good treatments, actually, and more all the time. And there's a lot of mythology around the treatments themselves, which is quite strange to me. I don't think anyone is forcing a woman to use this treatment or that treatment, But if it can help, then all the more power to her.
Absolutely. So what are some of the treatments that you usually recommend for specific conditions? That's a loaded question.
That's a very good question, and it's a very long answer, but I'm going to give the very short Reader's Digest answer. So we have a number of medications, both hormonal and non-hormonal, that can increase sexual interest and some of the downstream responses like lubrication, tingling, arousal, etc. We have some that can reduce anxiety about sex while increasing desire to have sex. And that's a slightly different category. And then we have a whole cadre of treatments for sexual pain. No one really wants to engage in any kind of activity where pain is the dominant sensation or feeling. We don't touch a hot stove on purpose because it hurts. We're just not going to do it. And if a woman's having pain, she's likely not to want to engage in sexual activity. And if she does, she's likely not to want to do it all that long. And if she doesn't want to do it all that long, then she's likely not to have much pleasure involved either. So it's just a vicious cycle that we have really good treatments for, both in pre-menopausal women and post-menopausal women. And we just are not using them that often because it's all supposed to be natural. Everything's supposed to work all the time.
Oh, no, I know we think that and everything should just work, but things change definitely as we get older. Hormones change, your life changes, your relationship changes, and you know we're lucky that we have some of the treatments that we have. Yeah.
I think that there are a number of simple things that I know you and I talk about with our patients, but that patients don't really appreciate. One of my favorites has to do with long-standing couples. So as a long-standing married person, you can get really routine and bored in the bedroom. And I often say to patients, you know, you've been married for X number of years or with your partner for X number of years. And I'll bet you can tell me the entire script. Think of it as a play. Act 1 ends in beginning Act 2, beginning Act 3, et cetera, et cetera. I'll bet you could write it all down exactly as it's going to happen. And most of the time, she'll say yes. And then I'll say, well, what if we changed and had a surprise ending? Wouldn't that be great if you could just have a surprise ending or a twist in Act 2 that led to a completely different storyline? And, you know, the light bulb frequently goes off, and it's important because many couples never think that way. And bringing a surprise, a different scenario, a toy, something to the bedroom can have a tremendous difference, even if it's not much of an effort. And my favorite one is to just call it a neurotic surprise. What would you bring to the bedroom if you were planning a neurotic surprise for your partner? Then, where in this play we've been talking about would you introduce your surprise? Or how would you introduce your surprise? And if you can get patients in our case or individuals in a couple to appreciate that they have control of those surprises, it's not uncommon that you can set them on a completely different course to how they approach their sexual lives together. And then maybe he brings a surprise the next time. Or in the context of date night, one or the other of them can bring a surprise. It can work miracles, and it doesn't have to be something that's expensive or that requires a prescription from a pharmacy or surgery or anything else. It's a real simple approach to just changing it up.
Yeah, no, I absolutely agree. I often tell couples to just pick a different room, pick a different time of day. It's free. It's totally uncomplicated, but even just going in a different room can sort of, spice it up a little bit. But yeah, I think I absolutely agree that couples, it's like they have their own sexual script and they need to change it up some. It's kind of interesting. I don't know if you listen to Esther Perel, her podcast. She's a sex therapist, and she's got a great book called Mating in Captivity. And she talks about how in order to still have that desire for your partner, you need something new and exciting and adventure. And having the same old sexual script just isn't an adventure. And I always find it interesting how she talks about that as a society, we've decided that we're going to be in these long-term relationships. And so it's sort of a trade-off, this long-term relationship, you end up with some, maybe not so exciting sex because you do the same thing each time. And she talks about how to make it an adventure. And I think adding a toy makes it an adventure, it makes it something novel and new and exciting. So yeah, I totally agree.
Yeah, and one thing that's really simple, you said adding a toy. As we talk about older women, but also for younger women, adding a lubricant, especially in someone as an aging woman who actually needs a lubricant, can be enough in and of itself. And I ask them to imagine how they're going to apply the lubricant, how they're going to apply it to him, to her, to them, etc. And this can interrupt the old script just enough, adding a little lubrication and thereby taking away any extra pain to make it much more pleasurable. And that's really easy.
Yeah, so I like that idea because, I talk about lubricant with my patients, but making it interesting, putting on the lubricant. You can make it not just hand me the Uber lube, kind of thing. You can make it part of sex play. So I really like that. The one thing I want to say about lubricant is I have heard from my patients that, when they start to go through menopause or perimenopause, that menopausal transition, and they're not lubricating like they used to, and they're not aware that that's because, declining hormone levels. And their partner might think, oh, why is she not excited by me anymore? And the patient of mine might be like, what's wrong with me? My body's not working. And, I feel like I do a lot of education about what happens with declining hormone levels. So women know it's not their fault. And then they can go tell their partners, unless the partner is sitting there in my office, that, it doesn't mean she doesn't like you anymore. That's what happens. So I feel like a lot of times just education on what happens, and then you can throw in that lubricant and make it fun. I like that idea.
You can also suggest, after explaining it, because explaining it is important, that if this is a heterosexual dynamic, what he might do to help her have more or longer stimulation, and thereby she gets more pleasure, there is more natural lubrication, and everybody's happier at the end.
Yes, yeah. And I think that sometimes when you have that set script, the timing, it becomes just quick, like quick, and you don't spend as much time building on that arousal. Definitely.
Absolutely.
And where do you fit vaginal estrogen or vaginal hormones into this picture of arousal and sex play?
So I think that estrogens are really an important part of both men and their sexual function and women and their sexual function. And estrogen has had, for at least the last 20 years or so, a very bad, dangerous reputation which has now largely been debunked
Yes.
and largely been taken back, with the exception of certain very specific circumstances, women being actively treated for breast cancer, for example. Estrogens are common in all the animal kingdom, and in humans, men actually have about the same amount of estrogen as a postmenopausal woman. So if it were that dangerous for postmenopausal women, all the men would have to go out there and have their hormones reduced because it would be dangerous for them as well. And it just is not the case. So low, small doses of estrogens or hormonal treatments, let's say, that act like estrogens, of which there are several, act like estrogens in the vulva, in the vagina, on the clitoris, on the blood flow in the area. They can improve genital health and improve sexual function in those women that have low hormones and are menopausal, or low hormones from any cause, because many young women may have very low hormones in the context of breastfeeding a newborn baby, of being very active and having a tremendous loss of body fat and their periods cut off, and then they have estrogens in the same levels or nearly the same levels as do women who are menopausal.
Yeah, and you're talking about estrogen and its role in orgasm and role on the clitoris. And one thing that I see a lot is that I think when women come in with some orgasm problems and they're postmenopausal, we need to remember that estrogen is the gas that makes the car go. So one of my favorite analogies is that if you are having trouble with reaching orgasm from clitoral stimulation and you're menopausal, that, a lot of women will say, oh my gosh, I try so hard. I use the most strongest toy and the most I can do and I can't get there. But the car's not going to go if there's no gas in it. So we need to give the estrogen back to the clitoris, including the vagina and the vulva, and obviously the clitoris, which is part of the vulva. But it's so important for so many reasons, that vaginal estrogen. And like you mentioned, the risks of low dose vaginal hormones are so small and the benefits are so huge, that I wish more people knew that. And I still feel like I battle the estrogen is bad battle every day. And you're right, things have changed.
Yeah, so we're all battling that estrogen battle. But I will say that slowly and progressively over the past 20 years, even the people who have waved the flag, hormones and estrogen is bad for you, are stepping back, reversing their points of view, changing the paradigm, coming around to the point of view that I've been espousing for a very, very long time, shall we say, with good data behind it. And I think we're coming more back to a more balanced view of the benefits and risks, at least in the scientific community. I think the average layperson has a long way to come yet to get a logical, evidence-based view of the benefits and risks. They don't know, for example, that having their 2 glasses of wine with dinner every night raises their risks of breast cancer, even under the worst of circumstances, about the same as systemic estrogen therapy, not even low-dose local vaginal estrogen therapy. So we just need a evidence-based approach to this, one that puts the benefits and risks in proper context. And most people will come out on the end of hormones are good for you. They maintain the tissues in a more youthful and functional way. And that's where we should all strive to be.
So I want to make one point about that. I've seen that chart where they say, having your glass of wine increases your risk, or more than 7 drinks a week, increases your risk of breast cancer more than does taking hormones. But that number, I believe, comes from the WHI, right? Estrogen and progesterone together. That's where that number comes from. But now we have more data that maybe it's not the estrogen per se, maybe it's the synthetic progestin. And so every time I say that, I feel like, well, but that's not really looking at estradiol and prometrium. That's looking at Premarin and Provera, and Provera is a synthetic progestin. So I know that statistic, but I feel like it requires more explanation. What are your thoughts?
You'll recall I said worst case scenario.
Yes.
I would argue very strongly with the data from the Women's Health Initiative itself, no manipulation, that in women who came into that study having not used estrogen or progesterone or progestogen, those that came in clean, so to speak, as clean study volunteers, they had no effect of Premarin and Provera, the two compounds that were used in that study. Even though it was a synthetic form of progestogen, they had no effect on breast cancer risk. All of the risk found in that study, and which made all the papers, all the noise, all of the strong public story about hormones and breast cancer, came from a very small number of individuals in that study who had used hormones before coming into the trial. And curiously, they went off of their hormones before coming into the trial. And if they'd been put in the placebo group, it lowered their risk of breast cancer, even lower than women who were on placebo and who hadn't had any hormones before. It's just the opposite of what everybody thinks. Hormones raise your risk of breast cancer. Not true. It's going off hormones reduces your risk of breast cancer. And we know that for at least 4 decades, because women going through menopause or surgical menopause had a reduction in their risk of breast cancer compared to no treatment. Not compared to hormones, compared to no treatment. So it's a complicated story, but women should not fear hormones, systemic hormone therapy, local hormone therapy as it relates to breast cancer. And you selected a natural form of bioidentical estradiol in your example, a patch, for example, or prometrium, which is a natural form of bioidentical progesterone. And there are some data to suggest that those two compounds together have no effect on breast cancer risk in large long-term studies. But I don't want to get too much into the weeds. It's really important that all of your viewers understand that hormones are not the bad guy, and they have a lot of benefits. And those naysayers who put forward a point of view that they have a lot of risks have been walking that back year after year after year, to now they're actually talking about the benefits of hormone therapy in menopause. And the North American Menopause Society actually is about to come out with their brand new guidelines on hormone therapy in menopause. And I truly believe, having seen some, but not all of the final document, that the tone is different. The indication is that there are some long-term disease-preventing benefits of starting hormones as young menopausal women. And that's a different point of view than hormones are bad for you, hormones cause disease, and there's no way that you can use hormones to prevent disease. That's not the case. We are in a different place with better understanding than we had 20 years ago.
And I asked this question at the North American Menopause Society conference last fall, but I always wonder about, you know, we know that in younger women, age 50 to 59 or within 10 years of their last menstrual period, that hormones can reduce the risk of cardiovascular disease. So, but we're not at that point yet to say, oh, you should take this, you know, to reduce the risk of cardiovascular disease. So I'll be anxious to read that paper when it comes out, to hear the tone and hear what they have to say about cardiovascular risk, because yes, you have to look at the risk benefit ratio, talk about the risk benefits and side effects, but there's a big benefit there. And what about someone who's got a strong family history of heart disease? You know, someone who's really working the best they can to do everything they can to lower their risk of having a heart attack or a stroke in the future. Who knows where we'll be on hormones in 10 years and the cardiovascular risk. So I'm looking forward to seeing where that goes.
Well, the American Heart Association this past year, and they're a very conservative organization, in their recommendations did have some language around reducing prevention of cardiovascular risk with hormones in young, early postmenopausal women. And so they're on board at least a little bit. They put their toe in the water. They haven't jumped in full head first, but they put their toe in the water. And it's, as I said, moving in the right direction, albeit very slowly.
Yeah. Okay, I got one more question for you on hormones. I'd love to hear your opinion on pellets.
So I wrote my first paper utilizing estrogen pellets in the late 1970s, believe it or not. And pellets are not new. In fact, they've been around for decades before that, before the 1970s. In fact, Stein and Leventhal, the people from Chicago who first described polycystic ovary syndrome, used pellets as an early form of treatment. So pellets are not new. My concern about pellets is that they are unregulated and the dosages are frequently, not occasionally, but frequently too high to be considered physiologic or normal for an otherwise healthy woman. That's particularly concerning to me as it relates to the use of testosterone pellets in otherwise normal women who are not trying to transition to be men. So in young women who are not trying to transition to be men, I think that there are better ways to get both estrogen and testosterone if they need them. The risks of too much estrogen and too much testosterone are in fact very real. And I express the risk from testosterone, which I've seen many, many, many times actually, as, well, would you like to end up looking like me, bald and bearded? Because if you stay on your testosterone pellets, and they don't come to me for those, then you're very likely to end up with those two problems. And it's not a particularly good look for a woman. And so there is some sense of either embarrassment or fear, which I think are both justified, because they're getting way too much estrogen and testosterone. I'll give you an example. It's a shocking example, but it's a real one. We have a plastic surgeon in suburban Washington who gives a lot of testosterone pellets to his patients. And then when they get very hairy, he sends them to his own laser hair removal center to get their hair taken off. I think this is unethical, but it's me talking. And I've also seen a number of women who grow small penises from their clitorises from having too much testosterone. And it's just not the right approach. If one needs estrogen or one needs testosterone, we have ample alternative therapies borrowed from men, I grant you, on the testosterone, but alternative therapies that can be used very effectively and safely in women.
Yeah, and I have seen that clitoromegaly, the clitoris grows, and it's a permanent change. It can't go back. So yeah, so I don't use pellets either, and I feel like there's a lot of misinformation on the internet about hormones and pellets. So I definitely wanted to get your opinion on the pellet issue. So.
Well, you've got my opinion. I think there is a place for pellets in men.
Mm-hmm.
They are FDA approved as a source of testosterone in men. And I think that maybe someday we will have a proper dose for pellets in women, but right now we do not even know what that dose is.
Right. All right, well, I've got one last question, and then I'll let you get on with your Friday. Just tell us a fun fact about you, anything in the world.
So I think that the fun fact about me is that I love to ride roller coasters.
Oh, I didn't know that.
Riding roller coasters since I was a youngster or teenager. And I love riding roller coasters. And we have about 200 so-called hyper coasters in the world. These are the biggest, fastest, longest, largest coasters. And I think I've ridden about 2/3 of them to date, but they're flung hither and yon around the world. And the COVID pandemic has really put a damper on my coaster riding. So that's the one fun fact that most people don't know.
I did not know that. That's a great fun fact. Well, I wanted to thank you for coming on this podcast. I'm so grateful to have such an expert, well-known. You're the Menopause Whisperer, right? You are the expert.
Actually, the Washingtonian Magazine did call me the Menopause Whisperer.
I love that. That's great. So, and I think it's wonderful that you're on this, and you know, we can work to help women learn about the changes that are going to happen and what's normal and what we can do about it so we can live long, happy, healthy sexual lives. All right.
Well, thank you very much for having me. And I look forward to doing another one as soon as possible. And I'll just tell your viewers, listeners, that I know both of us would be happy to help them in any way we can, whether they're local or via a telemedicine visit. I know that both of us are really indebted to our trainers and our educators, and hopeful that we can help bring the level of knowledge up for all of our patients and non-patients alike.
Yep. And where can we find you on social media if someone wants to follow you, and where can we find you in general?
So my name over here, Dr. James Simon. I have a very nice practice and website called Intim Medicine Specialist. That's INTIM, Intim Medicine Specialists. And I work in Washington, D.C., near the White House, and do telemedicine visits all over the world, and look forward to helping anyone who I can. We have a great website with tons of information, a YouTube channel, and Instagram, and the usual social media posts. But I prefer to talk to women one-on-one or with their partners, and hopefully we can solve whatever issues they have.
Fantastic. Well, thank you so much.
Thank you. Have a great weekend, and happy, healthy one.
Yeah.
Great sex to everybody.
Yeah, I love that.
Bye now.
Thank you for listening to today's podcast of Intimacy Unmuted with special guest Dr. James Simon. Dr. Simon is a menopause and sexual health leader with ISSWSH and NAMS, and Dr. Simon has also helped many women in reproductive endocrinology and infertility. Don't forget to like, comment, and subscribe if you enjoyed today's episode. Follow Evora Women's Health and Dr. James Simon on social media linked in the description below. Until next time, unmute your intimacy and stay sexy.